Welcome to Advanced Practice, where we put together excellence in mental health practice. Few medications in psychiatry have changed the field as profoundly as lithium. Lithium became the first medication capable of meaningfully stabilizing bipolar disorder over time. And even today, more than 70 years after its psychiatric discovery, many clinicians still consider lithium one of the most effective treatments in psychiatry. Lithium is not a designer psychiatric drug. It is a naturally occurring element. In fact, lithium is a simple alkaline metal on the periodic table, closer chemically to sodium than anything we traditionally think of as psychopharmacology. Its psychiatric effects were discovered almost accidentally in the late 1940s when Australian psychiatrist John Cade was studying severe mania and theorized that some toxic metabolic substance might contribute to psychiatric illness. He eventually administered lithium salts to patients with mania and noticed dramatic reductions in agitation, insomnia, grandiosity, and behavioral dysregulation. Over the following decades, lithium became the foundation of bipolar treatment worldwide. Lithium reduces the severity and frequency of manic episodes, but it also appears to reduce relapse risk over time. More importantly, lithium remains one of the very few psychiatric medications consistently associated with reduced suicide risk. And yet, despite its effectiveness, lithium remains one of the most underutilized medications in psychiatry. Part of the reason is complexity. Unlike many psychotropics, lithium has a relatively narrow therapeutic window. Small increases in concentration can shift patients from therapeutic benefit towards toxicity. Clinicians must follow lithium levels, kidney function, thyroid function, hydration status, and sometimes calcium levels. Dehydration, illness, NSAIDs, ACE inhibitors, and diuretics can all increase lithium concentrations and raise toxicity risk. Mild toxicity may present as tremor, nausea, diarrhea, sedation, or cognitive slowing. More severe toxicity can involve confusion, ataxia, seizures, arrhythmias, and neurological injury. Because of this, lithium developed a reputation for being difficult or even dangerous. Many experienced clinicians argue that psychiatry may have overcorrected. Concerns about long-term renal effects and monitoring requirements caused some prescribers to move away from lithium in favor of medications perceived as simpler or safer. But many of those alternatives introduce their own problems, including metabolic syndrome, diabetes risk, weight gain, sedation, and complex polypharmacy. In other words, avoiding lithium does not necessarily mean avoiding risk. Another important misconception is that lithium is simply a mania drug. In reality, lithium affects multiple domains of bipolar illness. It may reduce impulsivity, aggression, suicidality, relapse frequency, and possibly even neuroprogression. Some researchers have explored potential neuroprotective effects involving second messenger systems, glutamate modulation, circadian regulation, and neuroplasticity pathways. The exact mechanism of lithium remains incompletely understood even today. Modern psychiatry often prefers clean receptor-based explanations. But lithium reminds us that some of the most effective treatments in medicine were discovered clinically long before their mechanisms were fully understood. Of course, lithium is not appropriate for every patient. Some patients cannot tolerate tremor, gastrointestinal effects, cognitive dulling, or renal concerns. Others struggle with adherence, hydration consistency, or routine laboratory monitoring. Lithium dosing is highly individualized and guided by both clinical response and serum lithium levels. For acute mania, treatment often begins around 300 milligrams 2 to 3 times a day, with gradual titration based on symptoms and tolerability. Maintenance treatment commonly falls between 600 and 1,200 milligrams per day, though some patients may require higher or lower doses. Therapeutic serum levels are typically targeted around 0.8 to 1.2 mg per liter during acute mania and approximately zero point 0.6 to 1 during maintenance treatment, depending on the patient's age, tolerability, relapse history, and suicide risk. Because lithium is processed through the kidneys, dosing adjustments may become necessary in older patients, patients with renal impairment, or those experiencing dehydration, illness, or medication interactions. Despite the rise of anticonvulsants and atypical antipsychotics, lithium continues to occupy a unique place in psychiatry because few medications combine anti-manic efficacy, maintenance benefit, and anti-suicidal potential in the same way. And perhaps that is why lithium continues to endure. Not because it is simple, not because it is perfect, but because decades later, psychiatry still has not fully replaced what lithium can do. So that's it for today. Thank you for joining us. In the next episode, we will move into another major chapter in bipolar treatment, valproate. See you soon.